13, a lot of what we're going to be talking about tonight, on this chapter, we just talked about in chapter 13. So you'll have that comparison. So this one's fairly short. We're going to look at the difference in assessment between a conscious medical patient and an unconscious medical patient. Most of your medical patients are going to be what? Conscious. Most of them are conscious, so that's a real benefit. Or with your trauma patients, the majority of those are going to be conscious, but you're going to have a fair number of them that are not conscious. But with your medical patients, most of the time, they can give you a good accounting of what's going on. We're going to look at how to do a secondary assessment on a responsive medical patient too. And I know these things are confusing, but once you start assessing patients, you'll very easily understand these differences. We're going to look at how to tailor a physical exam for a responsive patient based on a body systems approach. And we're going to look at secondary assessment for an unresponsive patient. And you will see that the unresponsive medical patient is treated very similarly to an unresponsive trauma patient. Because if you've got an unresponsive medical patient, how are you going to get history? You're not. You don't really know what happened. You probably can't even rule out a trauma. You may have a patient that appears to be a medical patient, but it's a trauma patient. So you can kind of think about your unresponsive medical patient, you're going to treat them pretty much like a trauma patient. So then everything else will be your responsive medical patient. Okay, secondary assessment of the medical patient. Because remember, that top part of that sheet, they're essentially the same for a trauma patient or a medical patient. You're still going to manage your ABCs, right? You're going to rule out any life-threatening anything. If you suspect that there's other things going on where you need to do a rapid trauma assessment, then you may do that on a trauma patient. We have something like that in our medical file also, so we'll look at that. A responsive patient, they're going to tell you what's the matter with them. You'll say, what's going on? And they'll say, oh, my head hurts. Oh, my back hurts, or whatever it is. In that event, what are you going to focus on? Their chief complaint. And their chief complaint is whatever they tell you it is, right? It's really the reason they call 911. So with your medical patient, the problem with the medical patient is you can't really see anything. My head hurts. Is there anything when you check their body that shows you that their head hurts? Like, is their head going to be like swollen up really big or something? No, you hope not. So you're going to have to really hone your interview skills. And to me, this is the fun part. Now, most students prefer trauma because it's gory, it's neat, it's easy. You know, anybody can look, you know, at a smashed ankle and go, oh my gosh, he's got a smashed ankle. But how hard is it going to be then for you to figure out why somebody has a headache or why their stomach hurts? You know, you're going to have to do a lot of investigation to get that information. So for me, I find that a lot more fun, a little bit more challenging. And hopefully you'll get to that down the road once you got all that trauma stuff out of your system, which probably never. Your unresponsive medical patient, you're going to focus on whatever your physical findings are. They're unresponsive. Say you were doing your rapid trauma assessment on an unresponsive patient who's in their home. You think, you know, it's a medical patient. And as you're looking down at the legs and you see like these two little holes just above the ankle. They're about this much apart. What are you thinking? Dead-gum guy got bit by a snake. Of course, now we're looking at a trauma, right? So sometimes you're going to have to depend on that rapid trauma assessment for your medical patients too. So if they're responsive, it's going to be interview. If they're unresponsive, it's physical exam. So if they're responsive, you're going to start talking to them right off the bat. Tell me what's going on. How long has it been going on? What have you done about it? What does it feel like? Where does it hurt? Blah, blah, blah. Unresponsive, you're getting right down to your physical exam. Boy, that was quick. That's why this is a short chapter. That was easy, wasn't it? Responsive medical patient, history of present illness. Tell me what's going on. How long has it been going on? What does it feel like on a scale of 1 to 10? Blah, blah, blah. Has this ever happened to you before? Do you have a history of headaches? What did the doctor say about them? Did he say what caused them? Are you taking any medication? Then you're going to do a focused physical exam. If Ashlyn tells me she's got a headache and I've asked her all these questions since she's never had a headache before, after I've done my interview, Now I'm going to do a physical exam. I said, do you mind if I just kind of palpate your head? You know, I might start giving her this number and find she's got this huge old knot back here. Or worse yet, she's got a giant tick that's embedded itself up under her hair. You know, she may not have felt that, but I'm doing a physical exam. Well, no wonder you feel so rotten. You've got a tick the size of Rhode Island in your hair.
Which is a small thing.
It's pretty small, isn't it? Or is Delaware, is that smaller? I forget.
Rhode Island.
Rhode Island.
Okay, good. I picked the right one there. That's pretty random. I did take geography in high school. And then you're going to get your baseline vital signs. Baseline vital signs are important for your medical patients because they tell you a lot more stuff really sometimes than in your trauma. With trauma, it's going to be your physical assessment that's going to tell you most everything. So that's your responsive medical patient. History of present illness is going to come from the patient most of the time. If they're conscious, it's going to come from the patient. If they're not, you're going to ask bystanders. You see what happened here? Has she been sick? Does she take any medications? Do you know if she's got any history? This last one here is really important. Ask open-ended questions. What in the heck does that mean?
Not yes.
Not yes or no. What's your patient going to tell you most of the time?
Yes.
Yes.
Yeah, he's going to tell you whatever he thinks you want to hear. You know, if he wants you to think he's really sick, you say, well, does it like hurt when I push here? Oh, yeah, yeah. Does it feel like somebody's choking you? Yeah, yeah. Does it feel like somebody's stabbing you? Yeah, stabbing. You know, so don't give them that opportunity. Just like I mentioned to you about when you're doing a child, don't give them any options that you're not willing to follow through on. Didn't we talk about that one day? Yeah. So don't give them these options to say, oh yeah, I've got that. Oh yeah, I've got that too. Yeah, I've got that too. So ask them open-ended questions. What would be an example, Elliot, of an open-ended question? I've got chest pain.
Can you describe it to me?
Can you describe it to me? Is that a yes or no question? Yeah, it is. Try again. I can describe it to you.
Okay, on a scale of 1 to 10, 1 being least painful, 10 being most painful, what does it feel like?
Oh, it's a 7. How's that? What's the chance? 7. Can you think of an open-ended question, Jesse? You want to assess me? I've got chest pain. Y'all be thinking because I'm going around the room here. You haven't caught on to that one yet. You got one, Reed?
Chest pain?
Yeah. That's
When
a
did
good
it start
one.
hurting?
When did it start? That's good. Oh, a couple hours ago. You got an open-ended question?
What were you doing when it started?
What were you doing? Must have been that piano I lifted. Has this happened before? Yeah. Yeah, it's happened before. Oh yeah, well.
Is
try
it
again.
is it worse than or is it like worse now?
Okay. Is that kind of yes or no?
No.
You want me to
Yeah, but-
describe something to you, right? Tell me what the pain feels like. How did it feel last time you had this? You got one?
Where does it
Yeah, where does it hurt? You point to where it hurts. So there's a whole host of questions that you will ask that are not close-ended, but open-ended. So you have to kind of work on that because it's a technique to draw information out of your patient. If they've got chest pain, describe it to me. And if you just want to be careful that you don't put words in their mouth or thoughts into their mind. You want them to describe it. And sometimes, once they're having to describe it, it sounds very different than what they may describe if you said, is it a sharp pain or a dull pain? Well, it's a dull pain. That's kind of closed like that. You want them to describe it. Well, it feels like an elephant sitting on my chest. That's different than a dull pain. It paints a better picture for you. So you want your patient to paint a picture for you.
Can you paint me a picture of how your chest feels?
Do what?
I'm just going to ask them to paint me a picture of how their chest feels.
And give them a crayon and a piece of
There you
paper?
go. That's what
Yeah.
Think back to 30
You don't want to see my painting. Chief complaint, as we said, is why they called EMS and whatever it is that's bothering them the most. It may not be the most serious, but it's the one that stands out in their mind. Now, we haven't talked about history of present illness yet, but when you're getting history of present illness or current illness, this really is going to be your signs and symptoms for the most part. You're going to get this acronym, OPQRST. And this one is very important also. There's a few that we're going to get. Y'all remind me, I've got a handout to give you on this, and I'll try to remember to bring it tomorrow. OPQRST. Okay, O is what? So onset. What were you doing when this started? You want to know if something that they were doing caused the problem. Provokes. What makes the pain better or worse? Or palliation, sometimes they'll use that. What makes it better or worse? Like, well, when I'm laying down, it doesn't hurt. As soon as I get up, then it starts to hurt. Okay? That starts to narrow the field down for us. Quality. Describe the pain to me. You say, describe the pain, they're going,
It hurts.
yeah, it hurts. Well, yeah, but what does it hurt like? You've had your foot stepped on before. You know, did it feel like that? You know, did it feel like somebody took a stapler to your head? You know, describe what it feels like to me. Radiation. We want to know where the pain is and does it seem to move or radiate. Your chest pain patients, sometimes they'll say it hurts in the middle of the chest. When you ask them about radiation, they'll say, yeah, it kind of goes up into my jaw or down my left arm or across my chest, different things of that sort. You know, if they've complained of back pain, point to where it hurts, and then does it just right there, or can you tell, does it move anywhere else? The last one is severity. Is that the last one? No, there's one more. How bad is the pain? On a scale of 1 to 10, with 10 being the worst you've ever felt, and 1 being like almost nothing, how would you grade it? And they usually can easily assign it a number. If I ask you all that, like, how cold is it in here? On a scale of 1 to 10, Justin, how cold is it in here?
This is
A
pretty
10,
cold.
a 10, what do you say?
I'd say 2.
Is it what? A 6?
2, 3.
2? 5? A 2? A 5? 5? 4? Huh?
Not sure.
That's 10 being cold?
Yeah, 10 being really, really cold is causing you pain, and 1, I don't care about the temperature.
Oh, I think I'll say.
7, you're cold.
God, boy.
8. You're 1. It's good for you, huh? Okay, so let me ask you this. Does that really tell you anything about how cold it is in here?
No.
All it really tells me is your conception of the temperature. You know, how do you perceive the temperature? Now, if I adjust this and change it, now I come back 20 minutes later and say, okay, on a scale of 1 to 10, how cold are you? See, I've made it warmer. Now we're going to get different answers. So we can see a change. It's kind of like trending, because my 2 may be your 5. You know, my 5 may be, you know, your 1. So when we ask a patient this, we're looking for a trend. So if they say I've got an 8 out of 10 pain, we put them on oxygen, we calm them down, we put them in a good position, we cover them up, and we say, well, now what's your pain like? And they say it's a 5, then we've had a positive impact, right? So we're just looking for a trend there. It's obvious that everybody's going to feel it different. So, but always get that scale, whether it's pain, whether it's a respiratory distress, you know, where they're struggling to breathe. All the documentation people, they want this 1 to 10 on there now. So make a point of always getting it. Time is, when did the pain start? You know, an hour ago, 20 minutes ago, like how long have you been cold? Well, let's see, it's 20 of 7, an hour and 45 minutes. So this is history of present illness, OPQRST. So you need to learn those so you can go down. Now this is not exclusive. When you're asking a patient, you're going to pretty much get all of these when you're getting a medical history on a patient. But there'll be others that you'll fill in. You know, when you ask about provokes, what makes the pain worse, and when you're in there, you may even ask them, well, have you done anything to make it feel better? Have you taken anything? So there'll be other questions that you'll tuck in there, but these are the main ones, OPQRST. All right, past medical history. There's something missing here. We already did what? What's this looking like here?
Sample.
The sample history. So we got symptoms, signs and symptoms, allergies. What's next? Medications? Yep. What's next? P's? Pertinent past history. last oral intake and what were you doing when that happened? So there is some crossover there, but you're going to get this about their past medical history, whereas history of present illness or current illness. So you're really getting two sets of history here. Pertinent past medical history and then history of current illness. Okay. Tailoring past history. We kind of touched on that already. I don't care if you had your tonsils out. I don't care if you got run over by a car if we're worried about your anaphylaxis right now. So make sure that they tailor the history that you want. You know, you don't want to spend 2 hours on scene while this guy tells you every surgery that he's ever had, right? So make sure that you keep them focused on what it is you're trying to find out. Tailor it to their chief complaint. Ask questions pertinent to their complaint. Now, it might help you if you kind of go down body systems too when you're asking questions. You know, would you want to ask a patient, do you have any cardiac history?
No, because I might not know the
Yeah, what the heck is that? You know, you need to make sure you speak appropriate to the level of your patient. But most people, if you say, do you have any cardiac history, they're going to ignore you or they're going to throw out something because they don't know what you're talking about. So make sure you ask them in a way that they can easily understand. Have you ever had problems with your heart before? Do you have any heart problems? Take any medication for your heart? Tell me about it. But kind of go through the systems when you're trying to find out their complaints. You know, have you had any headaches or any problems with your head or dizziness or anything? No. How about, you know, your breathing? Do you have any trouble breathing or any problems there? No. You can kind of check off systems that they're not having a problem with. And then when you see where their problem is, their chief complaint, then you make sure you focus on that. Kids, when you're interviewing a kid, you know, after they're about 4 years old, you can usually start asking them questions and expect reasonably coherent answers or reasonably accurate. You know, take with a grain of salt. Get down on their level. You know, you look pretty scary. Even small people look scary when you're standing over a 4-year-old. So get down on their level so that you're looking eye to eye with them. Speak to them simply where they can understand it. Put it in layman's terms. You're also going to have to get information, of course, from the parents or the caregivers. Your focused physical exam. The focused exam is done on what kind of patient? Medical or trauma patient with no significant mechanism of injury. Okay? To do a focused physical exam on a medical patient, they have to be what? Conscious. That's right. Okay, usually this is going to be quite brief. Here, I don't know what's going on here. If the guy said his back hurts, you know, you can ask him all those questions. What are the questions we're going to ask about his back? The acronym? OPQRST. Yeah, and then we're going to do a physical exam. We're going to look at it. What are we looking for when we look at it? Another acronym. D, CAP, BTLS. Looking for deformities, contusions, abrasions, blah, 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 all those. But you're examining wherever he tells you it hurts the most or where his problem is. Then you're going to get your baseline vital signs. You're going to get baseline vital signs on every patient, unless you absolutely are busy doing something else. But 99.9% of the time, you're going to get at least one set of baseline vital signs. State of Alabama requires your PCR to have 2 sets minimum. If you don't have 2 sets, you better explain in there why you don't. And why do we get more than 1 set? The T word. We're establishing a trend. That's right. Okay. Where would you focus your physical examination on a patient complaining of shortness of breath? The respiratory tract. Yeah. Might check the mouth to see if there's any problem there, but you're mostly going to be auscultating, palpating, and what's the last one? Inspecting. Good work. Unresponsive medical patient. Ready for this guy? An unresponsive medical patient is going to be treated like what? Unresponsive trauma patient, because we really don't know the difference. Inability to communicate shifts initial focus for chief complaint and history taking. So we're not going to get that information, so we're going to jump pretty much to our physical exam. Same thing we do with the trauma patient. We pretty much jump to that physical exam, right? Then we're going to get our baseline vital signs. Hopefully we can get some history from bystanders. Oftentimes there's not anybody there that knows anything. You know, you got some little old lady that passes out at the mall. She was there shopping by herself. Nobody knows anything. How would you get information on her?
Maybe her wallet.
Yeah, look in her purse, look in her wallet. She may have some card there that tells you she's got a pacemaker or that she's allergic to who knows what. You may find medications in her bag that tells you if she's got heart medication in there, then maybe she didn't take it. She's got nitroglycerin. Going to get a little nervous. You're going to do a rapid assessment of the entire body. On the trauma side, we call that what? Rapid trauma assessment. We're getting there. On the medical side, we just call it a rapid assessment. But it's essentially the same thing. You're going to palpate, you're going to auscultate, you're going to inspect. That's the only way you're going to find any clues. With a trauma patient, usually you've got some kind of clues. You've got DCAT, BTLS. With a medical patient, you may not. Hope you find something. The main difference between a rapid physical exam, rapid trauma assessment, and then your regular detailed exam is going to be you don't really do much assessing of the face. You may check the pupils. Anybody unconscious, you're always going to check the pupils, but you're not going to spend a whole lot of time looking in the mouth and palpating the face and that kind of stuff. That's the only thing that you kind of gloss over. Important physical findings. These are important. That's why we call them important physical findings. JVD, what's that? Jugular vein distension. When you see JVD, what is it indicating to you?
No blood return to the heart.
Yep, blood can't return to the heart. It's backing up. So why blood's not returning? It could be a heart problem, right? It could be a failure of the heart, the ventricles to contract and getting that blood out. So blood doesn't go out, blood doesn't come in. What else could cause that blood to back up? What else could prevent that blood from flowing into the heart? Chest cavity may be full of blood or fluid or air, and because it's filled up the torso, then that blood can't return. So JVD is never good. Also look for any medical identification devices. They may wear something around their neck. They may also have something else in this area. They may have a pacemaker or an implanted defibrillator. So you'd be looking for that. The chest, you're always going to listen for breath sounds. It's not uncommon for a breathing issue to cause them to be unconscious. They could have fluid in their lungs. Who knows? Abdomen, we're checking for distension and firmness. If it's firm, that usually indicates what? It's full of something, usually fluid. It may be blood. It could be other fluids that may accumulate in there. So you're feeling for rigidity or firmness. It's going to indicate probably, usually an internal bleed. Distension, that means just is it larger than normal? And that can be difficult to ascertain on a large patient. It's hard to do that sometimes diplomatically. Are you always this fat? That doesn't sound so good, does it? You may get punched in the face. But, ask them, is this normal for you or is this a change? And that's probably one of the best things you can ask about. Is this normal for you? No. Yeah. Whatever. Pelvis. You're also checking for stability of the pelvis, but you're also looking to see if they're incontinent. You know that word, incontinent? That means that out of your control, you've either urinated on yourself or defecated. When do we see this commonly, particularly? Do what? Well, we do see a lot of that, unfortunately, when they're dead. Don't care about it then. Seizure patients very commonly will be incontinent, typically of urine, but it can also be fecal matter too. So you're always looking for that. If you've got a patient that's telling you, I've been having all these seizures all day long, and if there's no incontinence there, I'm a little skeptical. Can you have a grand mal seizure without wetting yourself? You can, but it's If you see evidence that they've been incontinent, that usually tells you. People don't urinate on themselves for fun. You know, it's like, I want them to think I really had a seizure, so I'm going to like pee all over myself. No. Most of them are going to draw the line there. Extremities, you're checking for pulse, motor, and sensory. You're looking at their skin. Is it warm? Is it cold? Is it dry? What color is it? Is it pale? Is it cyanotic? You're also going to check their oxygen saturation, and we didn't do that in labs last week, but we're going to do it tomorrow night. We'll talk about that. Determine if ALS is required. Anytime you have an unconscious patient, for me, I'm calling ALS. Unconscious people have a tendency to circle the drain pretty quickly on you, so if they're unconscious, I'm going to consider that. History of present illness, bystanders, get what information you can. If you can get the patient's name, sometimes they're going to have a chart already at the hospital where they've got some history that you can get. Find out, try what happened. Did you see anything? What do you know about the patient? Did he complain of something before it happened? Yeah, you know, she was sitting on the bench and she just kind of said she got dizzy and she just fell right off. Well, then, she had that. Patient taking any medications. These questions, after a while, they're going to come second for you. I mean, they're just going to roll off your tongue because you're always going to ask these. So when we go through our labs, this is one of the things we're going to be doing. You're going to be doing a interview on all of your patients, and these are the kind of questions you're going to ask. So it'll be fun. These are fun times in labs. What other mechanisms might you have to obtain? What other mechanisms might you have to obtain patient history other than speaking to bystanders? How else can you get information? Driver's license may tell them what? Their name, their address. Yeah, you may have an ID, a medical alert bracelet, and maybe on your ankle. What else? What, from the driver's license? Age is important. Yeah. Now, you may be in their home. Somebody called because they couldn't arouse Mama, so they called. They tried to call her on the phone. Can you think of anything else?
Whether or not you're an organ donor or not.
Whether or not what?
If you're an organ donor or not.
Would that be important to determine what's wrong with your patient, do you think? But you wouldn't want to know that. I mean, if you're doing CPR on somebody, you might want to know that. That is information that's available there. I was walking the neighborhood with my brother a few years ago in a new neighborhood. We hadn't lived there too long. And we saw this man come down the steps of his house with his dog. And just when he got to the foot of the steps, he just fell right over into a grand mal seizure. And he seized. And of course, we go over there. And after, if we got him stabilized, I went into the house because he left the front door was ajar. And he had, can you think of any reason I might go in his house and look for something?
Is there any type of medicine?
Yeah, did he have any medications? What would be one medication I might be looking for specifically? Seizure medication might be one. Insulin, if you have a diabetic very frequently can have seizures. Where do they store insulin? In the refrigerator. So if you've got an unconscious patient, you don't know what happened to them, you're called there for whatever reason, I'm looking in the refrigerator to see if they've got any insulin in there. So that would be another way to maybe get some history on a patient. Comparing assessments. If they're a responsive medical patient, usually we're looking at somebody without a life-threatening problem. We'll do our primary assessment, of course. We're going to spend most of our time on our patient interview. We're going to focus on what? Their chief complaint. Exactly right. Our physical exam will focus on their chief complaint. Our interview will focus on their chief complaint. We'll get vital signs. Take them to the house. Your unresponsive medical patient, we're going to treat them like what?
Trauma patient.
An unresponsive trauma patient. We're going to stabilize their ABCs, manage that. We're going to do a rapid physical exam, which is identical to a what? Rapid trauma exam, that's right. We're going to get vital signs. We're going to treat an unresponsive medical patient just like a unresponsive trauma patient. Get vital signs, get as much history as you can. Transport, we'll do a more detailed exam en route, just like the trauma patient. Makes it easy, doesn't it? Okay, history and physical exam of the medical patient takes two forms, right? Depending on what? Conscious or unconscious. If they're conscious, we do a focused exam, right? If they're unconscious, rapid exam. Work. A responsive patient, remember you're going to focus on your interview. You're going to get a good history of present illness, past medical history. We'll do a physical exam of whatever that one little problem is. Then we're going to get a baseline vital signs, if somebody hadn't already gotten those. Unresponsive patient can't communicate, so we're going to treat them like a trauma patient. Rapid physical exam, vital signs, and then interview, just like you do for your trauma patient. You may not change any field treatment as a result of the information gathered, but the results of the assessment may be important to the emergency department staff. So that's part of why we do this. We need to take a good history to the emergency department, because when you think about it, we go into a patient's home, we see them as they are. If it's a trauma, a car accident, we see the car, we see the environment, we see if it's flipped over 10 times. You know, we see anything else about that scene that may indicate why they were injured, you know, the mechanism of injury. You take a patient to the ER and all they see is somebody with a broken leg and a bruised hip. They don't know how that happened. They depend on us to paint that picture for them, so then they now can project about injury patterns or what's wrong with the patient, and it very frequently will color their treatment of the patient. Explain how and why the history and physical exam for a medical patient differs. We already did that. Explain how the history did that one. Okay, ready? You're trying to get information from a very upset son of an unresponsive man. So his dad's unresponsive and he's freaking out. He's the only available family member. He is so upset that he is having difficulty talking to you. How can you quickly calm him down and get history? What can you do? Somebody raise your hand.
Slap him around with
Yes. Trauma always helps that. Yeah. A little physical abuse. Yeah. That won't incite him at all.
Sit him down. Tell him how important it is for you.
Reassure.
Ask him to sit down, quiet down. Do what?
Reassure.
Say, he'll be fine.
No, you can't do that.
Yeah.
Tell him to breathe in his nose and out his mouth.
Breath
Yeah.
mints. Well, you need to. Here, I think I've got some stuff in here.
Tell him it's important for him to get you.
Exactly right. I can't help your dad unless you calm down and give me some history. So try to take a deep breath and see what you can tell me here so we can take care of matters. You got to calm him down and not let him just continue to freak out. Okay, do you have any questions about these? All right, not this week, but next week we're going to start our trauma assessments. So make sure you look over those sheets. And we're going to go through detail how to do these different assessments. Now, what I do want you to do for tomorrow night for lab, we're going to be doing our airway station where you're using the bag valve mask and the non-rebreather. I think we're also going to do a bleeding and shock station because we're starting trauma this week. We're going to do that first. So we're jumping to the back part of the book. We're not going to follow through medical. We're going to jump back and do trauma. We're also going to do some long spine boards tomorrow night. We're going to do vital signs. So make sure if you have your stethoscope, bring that. Bring your pen light. Remind me to get out the blood glucose monitor and the pulse oximeter in case I forget. And if you're interested in ordering a stethoscope, try to bring that stuff tomorrow night because we can go ahead and turn that in. She's going to make an order just for y'all. How many of you guys think you're going to order a stethoscope from Miss Judy? There's 2 or 3 of you? That's good. I think some from the other class may do that too. Okay, do y'all have any questions about anything?
Oh.
Oh.
We got a test, a quiz Wednesday tomorrow, right?
We do?
This says on campus.
What does it say? A test? Oh, that's not for you guys. That's for the other class.
It's on ours.
It shouldn't be on yours.
So the cardiac one?
Yeah.
Cardiac arrest
heart-
quiz?
Now, I
You
have,
got a CPR
You have a
one.
CPR.
You
Yeah,
got
you said
one
it's open
for
more.
that too.